Yo juro lealtad a la bandera de los Estados Unidos de América. Em, can you hear me all right?
Yeah, I can.
Good. Okay, we're going to start here pretty soon. Hope you're feeling better soon.
Thank you.
Okay, Emily, do the slides move?
No,
No. Now do the slides move?
no.
No. Okay. Okay, now do the slides move?
I don't see anything.
You don't see anything?
I see the definition slide, but I don't see it moving.
Okay, then we'll do it this way. Now, do you see it moving?
Yeah.
Now do the slides move?
Yeah,
Okay, then that's what we'll do.
perfect. Thank you.
Yeah. All right, we have a skeleton crew today. We have a bunch of people sick. As you can hear, I am dealing with a cold. If I get through this without coughing, it'll be a miracle. So. Some of you need to take the exam. I'm dealing with this in multiple classes. People needing to take exams and me having to hold the exam and not give it back. I think it is remarkably unfair for those of you who hadn't taken the exam to make your colleagues wait for a week and a half to get the exam back. So I am starting to think that a week is completely reasonable to allow you the time to take the exam. If you haven't taken it within a week, again, I don't control the weather. I don't control game schedules and stuff like that. But if you haven't taken it within a week, get your bloody shoes on and get the test taken. Holding the exam for over a week and not giving it back and not having a curve calculated and what have you is really remarkably unfair to your colleagues. So if you need to get the exam taken, please get over to the ASC and get it taken. Don't keep people waiting for a week, week and a half, 2 weeks, because I'm not going to wait indefinitely. I'm just not. You may have a score for the exam on Blackboard. That is a raw score. There's no curve that's been calculated yet because not everyone's taken the test yet. Only after everyone's taken the test will if there is a curve that needs to be done, will I calculate one and will you get your test back? So if you haven't taken the test, please make arrangements to take it as expeditiously as possible because I will not wait forever. I'm getting a little tired of people really, frankly, abusing my goodwill for weeks and so on and so forth, and abusing their colleagues' goodwill for that matter. If it sounds like I'm a little ticked off about this, it's because I am. So if you haven't taken the exam, make an appointment, get it done this week. I won't wait forever. All right. We talked about sickle cell disease, which is very prominent in African-American, Mediterranean, and certain types of Central Asian ethnicities that hail from those particular areas. Because of its usefulness at resisting malaria in those populations, sickle cell anemia, sickle cell disease, the allele, at least the S allele of beta globin, was present in the population at a certain level. Now that malaria-carrying mosquitoes have been exiled from those areas through use of heavy pesticide use, the frequency of those alleles in those areas are starting to wane, with the exception of areas where you haven't seen extensive pesticide use, like Africa and Central Asia and so on and so forth. So it was very common, for example, the word malaria comes from mal-aria, two Italian words meaning bad air. The Pontine swamps around the Pontine Hills, where Rome is a city built on 7 hills, that was an area filled with malaria. And it was you were thought to get it from the bad air that came from the swamps. Well, now we know it's mosquitoes that do it. That's how the disease got its name, and the name stuck, even though the name doesn't really apply. So this particular condition we're going to talk about today is present in Caucasian populations, people of certain European descent. So we're going to look at the consequences of cystic fibrosis, the consequences for male fertility as well. We'll look at the genetics. The genetics is kind of straightforward, but when it comes to the severity of the disease, it's not so straightforward. And then we'll take a look at the testing and the treatments for cystic fibrosis and what have you. So cystic fibrosis affects multiple organ systems. So it affects the skin, it affects the pulmonary system, the gastrointestinal system, the reproductive system, the exocrine endocrine system of the pancreas, which is connected to the intestines, the male urogenital system in particular, females not so much, more males, and then the hepatobiliary system, which is very tightly linked to the pancreatic system. And really any exocrine gland gets affected by this condition, this genetic disease. So the gene that is affected in cystic fibrosis encodes this cystic fibrosis transmembrane conductance regulator, which is a mouthful. So that gets abbreviated CFTR. This is a member of a group of transporters. They're called the ABC transporters. A huge group of transporters found in cells. They're found in bacteria, they're found in plants, they're found in animals, they're found in protozoa, they're found everywhere. ABC stands for ATP binding cassette. And you have a portion of the protein that binds ATP. When it binds ATP, the hydrolysis of ATP causes a protein to change its conformation, and that brings in whatever it's going to bring in. And members of this particular class, they take up amino acids, they take up sugars, they take up fatty acids, they take up ions, they take up whatever your little heart desires, pretty much. This group does it. The major cholesterol transporter, in fact, is a member of this group. It's a huge group of protein, big gene family. Well, this particular one is a chloride transporter. And loss of function mutations in this particular gene can affect the transporter chloride. Now, you might be saying to yourself, well, heck, we have a lot of electrolytes that get passed between cells in their environment, sodium, potassium, phosphate, what have you. What's the big deal about chloride? It's just another electrolyte. Well, it turns out chloride's a really big deal because remember, you don't have any active transport of water in cells. It doesn't exist. There's no such thing as a water pump. In your engine there is, of course, but not in cells, because water comes in membranes passively. Transport ions, you transport water with it. Water goes along for the ride. So the cell is a little bit lazy when it comes to water. It transports ions and the water comes with it. You get a two-for deal, essentially, with water. So if you transport chloride, you're going to transport water. If you don't transport chloride, you don't have much water. And so that causes your mucus to be very, very thick and to solidify and to get stuck in ductal systems. That's why the transfer of chloride ends up being so important when it comes to the mucus doesn't have much water in it. You ever had a cold and you get this mucus that just dries up and you blow your nose, part of your nose practically bleeds and won't come out because it's so dastardly dry. Imagine having that in your intestines or in your pancreatic ductal systems or in your lungs. That's what cystic fibrosis is like. So this is inherited as a recessive. It's a classic autosomal recessive. You need 2 copies of the mutant gene to cause a disease. And so people are carriers. And people who are carriers have a 25% of having a child who has cystic fibrosis. It's more common in people of Northern European descent. So Northern European descent would be Nordic. It would be the German lowlands, so the Dutch, the Northern Germans, those types of areas. So the incidence is anywhere from 1 to 3,200 live births. And approximately 1 in 25 people is a carrier. So I'll bet you we have well over 25 people in this building right now. If we were to take everyone out there and take them out to the quad and count them, say we have in this building right now about 100 people. That means there are at least 4 people in this building. The law of averages being what they are probably carriers of that gene. And it's most common amongst Caucasians in the United States. That's where you see it the most. So you will almost certainly see this in your careers.
Does that necessarily mean that somebody who isn't of Caucasian descent wouldn't?
It's less likely. It's less likely. It's virtually unknown in African American communities. Virtually unknown. That doesn't mean it's impossible, given intermarriage and things like that. But you don't see it very often. Just like you don't see sickle cell disease very often in Caucasian communities. Which tells you that the mutation probably arose in Caucasian lineages. So you might be thinking, what on earth is that? That is a crystal structure of the CFTR protein. It's a transmembrane protein. So it has a piece that you can see that sits in the membrane. And then the ATP binding cassette is down here. And when this binds ATP, it will change the structure. That then becomes a little pore for chloride. And the hydrolysis of ATP opens a pore, and the chloride, which will bind right there, are then propelled to the outside. And then it lets go of the ATP and the thing closes again, rebinds chloride, rebinds ATP, and the whole process starts all over again. So there's quite a lot known about this protein. In fact, the gene for this protein was cloned up the street at U of M. When Francis Collins, who just retired as the head of the NIH, was a professor there of human genetics. It was his group, his lab, where this gene was cloned. So cystic fibrosis tends to have rather profound phenotypic effects, even very early in life. So you see usually failure to thrive and a poor growth rate. You don't have good absorption of nutrients. That's due to pancreatic insufficiency. That pancreatic duct, remember the pancreas is a bit of a two-tone organ. It's a little bit country, a little bit rock and roll. It's a little bit exocrine and a little bit endocrine. Well, a lot of exocrine, a lot of endocrine actually. The exocrine part, an exocrine gland is defined as, Cassidy, define an exocrine gland for me. Into a ductal system. Yeah, exactly right. Exactly right. And Bree, an endocrine gland secretes their stuff into where in the body? Huh?
I'm confused.
You're confused. Endocrine means it secretes it directly into the bloodstream. That's endocrine. Exocrine means it secretes it into a duct. A duct. So the exocrine part, that would be the part that secretes all those cool enzymes, all the bicarbonate, mucus, stuff like that, all get secreted into the duodenum. That's the exocrine part. So the acinar cells, those acinar clusters, they're all connected by ductal systems. Well, those ductal systems get clogged by very thick mucus that doesn't have enough water in it. So instead of running, it stays in put and just gets hard. It's kind of like when you pour cement and then you come here kids, put your handprints in it, so on and so forth. So this is like quick dry cement. Instead of putting cement in a flow, you just put the cement in and it dries. So that's what happens. And so the pancreas secretes, and it doesn't get to the bottom. So nothing can get broken down, so it can't be.
Great question, but we were talking about breast cancer and like the ducts and like breasts. Would that also have an effect, or is that not an endocrine? Exocrine?
That is an exocrine gland. In fact, it's modified tissue-wise. It's a modified sweat gland. So physiologically very different, but when it develops a lot like a sweat gland. It just kind of goes to town, so to speak, with the ductal systems and what have you. Sweat glands are solitary. This thing forms in whorls, and of course, a lot more responsive to hormones and what have you. Women who have cystic fibrosis, they're fertile. They can't get pregnant. They may have trouble getting pregnant, especially if their fallopian tubes are full of really dense cement-like mucus. They can breastfeed too. The breast can get clogged and they can get mastitis, but there are ways to deal with that. So yes, it can get clogged. Yeah. But early in life, this is one of the first things you'll see is pancreatic insufficiency. And consequently, it gets missed. It's misdiagnosed. They have celiac disease, they have pancreatitis, they have asthma, they have chronic bronchitis, they've got all this other goofy stuff going on. So it's easy to misdiagnose it. So there is a very easy test essentially to run. First of all, pancreatic enzymes, because they're not getting into the duodenum, they will tend to then get leached into the bloodstream. So there is an enzyme you'll find in the blood. It's trypsinogen, and it's called immunoreactive trypsinogen. So this immunoreactive trypsinogen test looks essentially for trypsinogen in the blood. You shouldn't have that in the blood, but if you have that in the blood, that now starts to tell you, something interesting might be afoot when it comes to the pancreas. The other thing you see with cystic fibrosis patients, they release enormous amounts of chloride into their sweat. And you can quantitate how much chloride is in the sweat doing something called a pilocarpine identiphoresis test, otherwise known as a sweat test. Since pilocarpine identiphoresis test doesn't quite roll off the tongue, sweat test is usually the way it's put. So in the lungs and pancreas, the mutant CFTR gene means that chloride can't go out. But in the sweat glands, the mutant CFTR doesn't let chloride come in. So the chloride all stays in the sweat. So if chloride levels are high in the sweat, and you can see this essentially, the way this is done here, you have a little electrode there, and you have a little piece of filter paper on gauze, and you can essentially take that piece of gauze and you can test it for how much chloride is in there. This is easy to do because you take that and test its conductivity. More chloride in it, the more conductivity it has. And so you simply take it and you clamp it and you test the conductivity and it tells you how much chloride is in there because you use the Nernst equation. Well, the computer does the Nernst equation. You don't have to. But so the computer, you just put it in, it tells you how much chloride is in there, which is pretty cool, frankly. So this type of test, if you have over 60 millimoles per liter, then a diagnosis of cystic fibrosis is pretty likely because there aren't many other things that cause high chloride in the sweat. Now, sometimes you don't see this nice clear cut over 60. Sometimes you get something that's more borderline. Well, it's 30 to 59. In that case, yeah, it's possible. So 30, essentially, if you're above 30, that's the things that make you go, kind of range. So this test won't always give you a clear-cut positive. Sometimes it gives you that, well, kind of maybe.
Is there like a normal amount of chloride that's usually in?
Yeah.
sweat?
Yeah.
Just under 30?
It's under 30 usually. You have some chloride usually and some sodium. The sweat from your brow gets in your mouth and it's a little bit salty, and that's from the sodium chloride that you're getting rid of in the sweat. So a normal sweat test doesn't necessarily exclude cystic fibrosis. That's one of the biggies. You're going to use essentially several lines of evidence to establish whether or not the patient has cystic fibrosis. So DNA testing is going to be important, but so is a medical history. So is a medical history. So in people with CF, because of that thick cement-like, I keep using that metaphor, but I think it's appropriate because really, ductal systems, they get plugged. They get terribly, terribly plugged. Because of the plugging of the respiratory system, you get microbes that are trapped in these areas. Some of them will grow very nicely in the mucus. Others will thrive essentially in those trapped areas. And so Staph aureus and Pseudomonas aeruginosa are common causes of pneumonia in people with cystic fibrosis. You can also get sometimes fungal infections with Aspergillus fumigatus, and Aspergillus fumigatus is not nearly as common. It's more likely for them to have a bronchopulmonary allergic type reaction to it. The upper airways, you'll see polyps and nosebleeds, chronic sinus infections, and many of those will be resistant to your first-line antibiotics because they've been treated with them so many times. So there is this version, essentially, of certain antibiotics that are aerosolized that you can use for Pseudomonas. There's the Cayston, for example, Astrinum. Astrinum is available in an inhaled form. It's called Cayston. That is used pretty specifically for cystic fibrosis patients. You can also use an inhaled mucinase. And this is it's an enzyme that breaks down the DNA that's in mucus that tends to make it run better. And this is an inhaled form. They can take that and that will tend to break up the mucus as well. The other thing that these patients will need to do is they have these big balls of mucus and you need to just kind of percuss the back and break up the mucus balls. In fact, Francis Collins tells a story. He had a student in his lab who worked on the cystic fibrosis gene. He was a cystic fibrosis patient. And his girlfriend, who later became his wife, their ritual was she would sit there and beat on the back of his chest, on his back, to break up the mucus balls every night. And that would allow him to breathe. She said she got very strong from on his back trying to break up the mucus balls. So because of that thick mucus production, you get inflammation. You get lots of neutrophils usually that build up, and so you have chronic coughing. You may or may not have sputum. Sometimes the thick mucus is hard to come up, but you'll also have chronic bronchitis. Because the lung parenchyma will have areas that are essentially where you have air trapping, you'll have abscesses and then maybe cysts, fibrosis as well, and that increased pressure in the lungs also plays havoc with the circulatory system coming from the right side of the heart to the left side of the heart. And that can cause a type of right heart failure that's called cor pulmonale. That is actually a feature that you see in people with cystic fibrosis. Giving medications essentially to deal with pulmonary hypertension are usually necessary in those cases. So to test patients, you can use spirometers. I showed you a spirometer in farm, but this essentially is one of these. And then you can do these peak flow meters. This essentially you just blow very quickly. With this one, you're sustaining. You blow into it, you sustain it essentially for about 3 seconds. So this is a forced expiratory volume test, which you probably did in lab for AMP. But this essentially is a device that you use. Usually, if you work on a floor where you're giving these types of tests, you'll have one of these. You just keep it in your pocket or something like that. Peak flow meters, they have these in the room sometimes in the drawers. You just pull these out, there are mouthpieces. You just put them on and say, give me a nice big huff and puff. And this is good because it tells you if the medications essentially are working. So there's a baseline. If you're seeing increase over baseline, it tells you that the bronchodilators you're giving or something like that are actually working. So these are your friend when it comes to treating cystic fibrosis patients. There, that's better. Because of all the structural changes, you have lots of inflammation, and that's going to make vessels very fragile. So you have a lot of coughing of the blood, so-called hemoptysis. And that blood loss can be constant, and it can take its toll. So iron deficiency anemia is actually relatively common in CF patients. And in a chest x-ray, when you look at the chest x-ray, you may see so-called hyperinflation, where the alveoli, instead of the alveoli being just regular size, they may start to get hyperinflated. So bronchiectasis, that refers to this chronic condition. This is due to hyperinflation. You see the walls essentially of the alveoli, they start to thicken from inflammation and repeated infection. You can see the thickening essentially throughout here. Normally this would appear pretty transparent, but you can see in this case, it's very visible because it's thickened, and that's just due to this relentless plugging, unplugging, infection, inflammation, plugging, unplugging, infection, inflammation. This repeated trauma to the vascular tree will tend to cause the bronchiectasis. The pancreas, because it's an exocrine organ, it's involved too. And in fact, it's one of the first organs where you normally get plugging of the ductal system. So that thick mucus, it obstructs usually the cystic duct that goes from the pancreas to the duodenum. And so this chronic obstruction actually causes those enzymes to back up in the pancreas. Eventually they become auto-activated and they start to digest the pancreas itself. So you start to see pancreatic insufficiency, and people with cystic fibrosis have to take oral enzymes in order to degrade their food, in order to get enough nutrition from it. There was a movie about a cystic fibrosis patient and another cystic fibrosis patient, and I guess it was a romance movie. You saw it, what was it called?
6 feet apart.
6 feet apart, 6 feet apart. My middle daughter saw it and she said, "It's puberty love, Dad. It's got nothing to do with medicine. Don't watch it." Because I was telling her, "Oh, it might be interesting." Like, you said, "No, it's a puberty love type of movie. Don't waste your time with it." And I thought, "Oh, okay." So I took my daughter's advice. But that essentially movie, I think, was meant to show you the trials and tribulations of being a CF patient. And so, Cystic, you saw it. Did it represent the medical part at least with some accuracy, or was that pretty secondary to the story?
I don't know if when I watched it, I knew that much about what was accurate or not, so I can't say. But
Okay.
I think they're on the right track.
Okay. One thing, again, this is just from seeing trailers, just the drugs, lots of drugs they have to take every day, and that is true. So one of the drugs, in fact, in the trailer, when they showed the pills that I noticed just from the PDR, looking through the PDR one day, one of those pills was these enzyme additives that they need to take. The other was pretty obviously certain antibiotics that they need to take if they get infections. And the other, I think I recognized it, but I'm not completely sure. Well, anyway, without this proper pancreatic workings, you can't break down complex sugars, you can't break down fats. So you tend to see fats in the stools. That's called steatorrhea. And because that duct from the pancreas also is a duct that bile is used, that the liver uses to give to the gallbladder, then get to the duodenum, that bile starts essentially to backwash into the liver. That can start to damage the liver. So now you get disorders of blood coagulation because of the damage to the liver as well. And this will cause bilirubin buildup. That will tend to cause rashes. You may start to get icterus in some cases. And of course, anemia, because you can't properly absorb nutrients, iron, and things like that. Now, because the pancreas get backed up eventually, the endocrine cells of the pancreas also take a beating. And so you see cystic fibrosis related diabetes mellitus. This doesn't happen right away. It tends to happen gradually, but someone becomes more and more deficient in insulin production as the pancreas really starts to get picked apart by its auto-digestion, essentially. So in a newborn baby, the thick secretions will affect the so-called meconium. The meconium, very simply, is the first stool of the baby. So the meconium can get so thick and sticky, it actually gets stuck in the baby's intestines. And it won't come out, and that causes small bowel obstruction in the baby. This is called a meconium ileus. So the baby won't pass its meconium within the first day of life. And if you get a baby who doesn't pass the meconium within the first day of life, that might be an indication you either have some sort of atresia or something of the bowel. That should have been spotted on an ultrasound. That's usually pretty easy to spot in ultrasound. Or you may have a situation with cystic fibrosis. So the bowel obstruction can also cause bilious vomiting, where the vomiting is full of bile. Bilious vomiting, and then you get abdominal distension as milk and what have you starts to build up behind that obstruction. The rectal exam will show that the rectum is empty. And you'll also have normal sphincter tone. That tells you it's not Hirschsprung syndrome. Hirschsprung syndrome is a result, or Hirschsprung disease is a result of a lack of innervation of the lower part of the bowel. So the normal sphincter tone is a sign it's not Hirschsprung disease. The meconium ileus is a surgical emergency. It can lead to bowel perforation and peritonitis. That can lead to septic shock and either organ failure and ultimately death. So this meconium ileus is not anything to mess with. In a meconium ileus, the abdominal X-ray will show dilated bowel loops. You'll have air-filled levels proximal to the obstruction. It'll look a little bit like soap bubbles, essentially, in the bowel. So you have obstruction, kind of a ground glass almost appearance at the side of the obstruction due to small air bubbles that are mixed in with the meconium. If it calcifies, that usually is a sign of intraperitoneal meconium, which is a case of a meconium peritonitis. That is very serious. So to treat a meconium ileus, you have to do something called a decompression of the GI tract. You use a nasal tube, a nasal gastric tube through which you give IV fluids. If there's no perforation, no peritonitis, then you use a hypertonic contrast enema to break up the meconium. If that doesn't work and there's no perforation and peritonitis, then you have to do surgery and cut out the portion that has the blockage, essentially. So pancreatic insufficiency in early childhood is a prominent effect of cystic fibrosis. Simply, the pancreatic ducts are all jammed up. If someone's pancreas is not working properly and you suspect they might be diabetic, what's a nice fast test you can do on them? Any guesses, anybody? Can you test their blood sugar? That pretty fast test? Really fast test. So fasting blood sugar, if they're diabetic, what should their fasting blood sugar be? What's the number that after above which you start to say, we've got a problem here? This is a number you guys need to know, 100 mg per deciliter. If it's above 100 mg per deciliter, we've got a problem, Houston. Now, if it's 101, usually 104 is the number above which people really start getting concerned. So above 100 to 125, that's pre-diabetes. Is above 125, fasting glucose, you're diabetic. You're diabetic. And then to confirm that, you might want to do a hemoglobin 1AC, the glycated hemoglobin. Very good. So the liver, because it starts to get obstructed as well, you'll get biliary cirrhosis. And then because of this continued blockage, you're going to start to get the retention of fluid in the liver. That will cause portal hypertension. Now some of the veins that feed the liver, they're going to start to inflate. So you start to develop things like esophageal and gastric varices. Those varices can bleed more easily. Liver disease is the second leading cause of mortality after pulmonary disease in patients with cystic fibrosis. And the meconium ileus affects about 20% of the kids with cystic fibrosis. And in the absence of proper pancreatic activity, because the pancreas is plugged, the dense meconium is retained within the fetal intestines. This is meant essentially to show you what the X-ray looks like. You see the loops and you see the kind of, see the air pockets in there, what have you. And there's your obstruction right there. So it's in the transverse colon, just as the ascending colon starts to become the transverse colon. And you see the loopiness of it with the kind of soap suds look to it. That's really, really characteristic of it. Here's what a calcified meconium peritonitis looks like. And this is a pretty dire situation. Again, there's kind of soap suds, air pockets, but you can see the calcification there. This is very serious. Very serious. And it says up there surgical emergency, and that's, yeah. Call the surgeon and call the chaplain. Because not a lot of kids survive this sometimes. Now, in the seminiferous tubules, where the sperm are made, you also have mucus. And that mucus is really thick, just like you have in the lungs and in the GI tract and so on and so forth. So sperm get trapped and they don't make their way properly to the epididymis. And if they get to the epididymis, they really don't get out of the epididymis to the vas deferens. So just about all men with cystic fibrosis are infertile for that reason. So the congenital absence of the vas deferens can occur as the only feature of a cystic fibrosis causing mutation in men. And there are some mutations that don't cause a lot of gastrointestinal or pulmonary symptoms, but they don't have any sperm in their vas deferens. So it's very common for CF males to be infertile. Females with cystic fibrosis, they're ovulatory. They may, and I have to emphasize may, some CF women get pregnant just fine. But they may have difficulty getting pregnant if their cervical mucus is abnormal. OBs have ways to fix this. So CF, females with cystic fibrosis can become pregnant, but they may have trouble. But with a little help from their OBGYN friends and their OBGYN friend nurses, nurse friends, they can get pregnant usually. They may, in some cases, have to resort to in vitro fertilization. Depends on the health of the mother. If the mother handles it pretty well, she's pretty healthy, she may be able to give birth. If not, she may have to do the whole in vitro thing. So this chloride transporter is the only gene associated with this condition. And this chloride channel This channel has been worked on ad infinitum, ad nauseum, ad mecum siccum, and it's still not well understood at all. There are particular members of this group of transport proteins that are extremely well understood. Those proteins have not helped a bit when it comes to how this bloody thing works. So how this thing works and how the mutations affect it, still a little bit of a black box. So under normal physiological conditions, it kicks chloride out of the cell into the mucus, and water joins it, and the mucus is nice and hydrated. Excess sodium uptake is inhibited, and you get the proper water balance in your secretions. If you don't have that in the lungs, without proper chloride transport and enhanced sodium absorption, you get a net increase in water absorption consequently. So it thins the airway water content. The mucus, therefore, doesn't have as much water. It's very thick. You have decreased ciliary clearance because instead of clearing mucus, these things are starting to try and clear icebergs, if you will. And so bacteria, because the mucus is increasingly sticky, they adhere to the airways, they hide in the mucus, they grow in the mucus, and white blood cells either can't handle them or can't find them because they're hiding in the mucus. It's kind of like your body synthesizing a tank and saying, here, soldiers, hide in the tank. And so now the soldiers are all in the tanks. When the white blood cells come out to deal with them, they're not dealing with soldiers, they're dealing with tanks. Yeah. There are treatments. There isn't a cure. People thought after the gene was cloned that a gene therapy treatment was on the horizon. No, still not. It was. It's better now than it was even 20 years ago. It gets better and better with better and better drugs, better and better antibiotics. There are people who with cystic fibrosis used to not live past 30. Now they're living into their 60s and 70s. So they will have their share of mishaps and they will have trips to the hospital. Also, people with CF, depending on which allele you have, they vary as to their severity. Some have very severe disease, others, their disease really isn't that severe. So that's going to affect it too. So, and it's very hard to tell from which alleles they have how severe their disease is going to be. That's the other feature about this disease, that it'd be befuddling. With other diseases, certain alleles correlate with severe disease, others correlate with mild disease. That's not the case here. So this disease still has a lot about it that's just not well understood. So when it comes to the types of mutations that you see in that CFTR gene, you have things that take out bits of it. You have things that prevent you from making a full copy of it. You have a stop codon in the middle of it. You have frame shifts, so you make the protein and then the rest of it is nonsense. You have splice site mutations that prevent proper splicing of the gene, so you get junk protein. And then you have missense mutations that partially alter the function of the protein as well. Now, some of these missense mutations present symptoms later in life. They are associated with milder disease. These up here tend to be associated with more severe disease. That we can definitely say for sure. It seems pretty clear that the more functional transporter you have, the better your clinical presentation, the less severe your course of disease. That seems to be something you can bank. But again, there's a good deal about this condition that is really hard to get your head around. So the most common allele is something called F delta 508. So this protein is missing the amino acid phenylalanine, which should be the 508th amino acid. It's missing that particular amino acid. Now you might think, well, it's just missing one amino acid, so the protein's probably fine. Au contraire, if I might disagree with you, it turns out this protein, when it's made in the endoplasmic reticulum, gets transported to the Golgi apparatus, and then it goes haywire in the Golgi, and it never makes it to the membrane. So this single amino acid deletion essentially produces a protein that never makes it to the membrane. Now, there are some drugs that have been designed. They're small molecules. They actually bind to this protein, and they help it fold properly, and they help it get to the membrane. And so these drugs are oral drugs. They actually can get wild type copies of protein to the membrane. And if you stay on these drugs, your cystic fibrosis essentially goes away, which is pretty cool when you think of it. So I have a Vactor and some of these others. It's a 3-drug combination now of 3 different drugs. They bind to this mutant protein. They cause it to fold properly, and they bring it to the membrane. And now it works. So these 3-drug combinations now can be given to people who have that allele. It only works if you have that allele. Fortunately, this is the most common allele of cystic fibrosis. If you don't have that allele, not quite much else we could do for you. So diagnostically, you can take a look at the sweat test. There's also another test called a transepithelial nasal potential test that can corroborate essentially the results of the sweat test. There are also very good genetic tests. The CFTR gene is a big gene, and finding essentially the tests that are available, look for the mutations that have already been found. So if you have a new mutation in the CFTR gene, you'll miss it unless you sequence the whole gene. Most of these tests are made essentially to be able to detect particular alleles. These tests are commercially available. They come essentially as panels. So you can ask for a CFTR panel, and they'll detect essentially some of the, start at the ones that are found most often and then go down from there. If you didn't know you were a carrier, you can have yourself tested with the child, usually for a few extra bucks. Well, it's more than a few extra bucks usually. But typically, your insurance will usually end up paying for that because it's worth it to know if you're a carrier, if you want to have another kid. So the sweat test has about a 90% accuracy rate. That will tell you if something's up. And then the molecular test is ordered after the sweat test. The sweat test is easy, it's cheap. You can do the sweat test in a doctor's office in half an hour. That's why the sweat test is done first. The gene test, you have to swab the buccal cells from the cheeks and send that out. That's more expensive. So you do the sweat test first. Then usually there'll be a bowel ultrasound. And then a symptomatic assessment, essentially, of the baby. And if any of you guys do peds or family medicine, my guess is you'll run into somebody with cystic fibrosis. You do get cases where the sweat test is inconclusive and the mutation testing is either not available or it's inconclusive. They get some sort of mutation that's a newfangled mutation that the test doesn't detect. In that case, you can use a transepithelial nasal potential different measurement for your diagnosis of cystic fibrosis. You don't need special equipment to do this. That can usually be done. You can also, in newborns, look for the immunoreactive trypsinogen assay. So the IRT test. IRT test, you will just need some blood. You send that out. That is not an expensive test either. And that is part of a panel for cystic fibrosis usually. And if the doctor's office where you work doesn't do that, you can usually send them to a hospital or someplace that will have this equipment. Usually not an issue. All right, so let's take a look at the genetics of cystic fibrosis. So if we have, say, someone, we call that the wild type copy of the CFTR gene. And we call that the mutant version. If you get two copies of this, you're going to have cystic fibrosis. So if this individual is a carrier, that person's a carrier, do our nice handy dandy Punnett square. That person does not have cystic fibrosis and they're not a carrier. That person does not have cystic fibrosis, but they are a carrier. That person does not have cystic fibrosis, but they are a carrier. This person has cystic fibrosis. So 1, 2, 3, 4, 1 out of 4, or 25% of your offspring are carriers. If your offspring has a 25% chance of having cystic fibrosis, they have a 50% chance of being a carrier. And they have a 25% chance of not being a carrier. I did that pretty quickly. I assumed that this was self-explanatory. That may not be the case. Is there anybody who wants me to go over this again? No? All right, so that essentially shows you the power of the Punnett square. So when we say affected proband simply means progeny. So we have a 1 in 4 chance, 25% chance of being affected, of having the condition. That is very characteristic of a recessive condition, autosomal recessive condition. And you have half a chance of being a carrier, but remember, carriers are asymptomatic. 1 copy of the gene will make more than enough CFTR protein for your body to be able to function normally. So the ACMG, the American College of Medical Geneticists, recommends that all Caucasians of non-Jewish descent and Ashkenazi Jews be tested for cystic fibrosis. So there's a panel. It's commercially available. There's, I think, 2 companies that do it. There's one I know for sure that does it, but it's a panel of 23 different known mutations that are the most common that appear in populations in the US. This panel of mutations picks up about 92%, 2 or 3 or 4%, 90-ish, low 90-ish percent of all cystic fibrosis mutations. Does it pick up all of them? No. If you have an allele that's not detected by this test, and if your allele is not very severe, and your kid essentially has a normal sweat test, they might manifest symptoms later on in life, but they don't manifest symptoms as a baby. May be very difficult to detect it. I have to emphasize this again because students often trip over this. If they have a panel of 23 alleles and they come up, empty, can you guarantee them they don't have cystic fibrosis? No, you can't, because these tests have limits. So I think young clinicians very often, they get in the habit of overpromising. And you can't do that with medical technologies. Medical technologies have limits. Because they have limits, you can tell them the chances that you have it are low. Are they zero? No, they're not zero. And you have to be honest with your patient because of limits on the technology and limits of your knowledge. You're not omniscient, are you? I think you are. Watch the movie Bruce Almighty. You're not. So don't overpromise. I think young clinicians get in they make big mistakes because you see it's negative, you get excited, you want to share that with the patient, you want to be excited with them, but you have to temper what you're telling them and say, as far as we know, data in hand, you don't have it. Is there an 8%, 7%, 6% chance you have it? Yeah. So there's a chance. So again, don't overpromise. So Rebecca's question earlier on, I think was a good point. What determines essentially if a CF patient is going to survive into their 50s or 60s or 70s or something like that? And it's very simply, they have a plan, and it's a comprehensive plan that is going to determine what their treatment's going to be. So they have to have essentially all these things in place: bronchodilators, supplements for pancreatic enzymes, mucus thinning agents. These are getting better and better and cheaper. Pain management, anti-inflammatory agents, chest physiotherapy, antibiotics to manage the respiratory agents, standing orders for them, things like that. If you're on top of this essentially, and there are clinicians now who specialize in treating CF patients, and you follow this person from being a kid all the way through being an adult and so on and so forth, they can have a life essentially that's relatively normal. So that treatment plan is really important. All right, we are out of time. We'll finish this. And the next piece we'll get into is osteogenesis imperfecta. That's a very interesting genetic disease. We'll take a look at osteogenesis imperfecta and go from there. All right, for those of you on Zoom who have not taken the exam, please find a time to take it. And you can get it at the Academic Support Center. Go see Amber Holloway. She's the contact person. Send her an email, make an appointment. Please try to get it done by this week. All right.